The views and opinions expressed in the following program are those of the participants and do not necessarily reflect those of KSMQ Public Service Media Incorporated or its assigns.
Tonight on Health Connections, we'll look at some causes and effects of insomnia. We have a health expert here in the studio to answer your questions. Stay with us. You're watching Health Connections. Welcome to Health Connections. I am your host, Stacie Beecham. Here with us tonight is Dr. Steve Kubas, a board-certified sleep physician working in the sleep medicine program at Austin Medical Center. Welcome, Dr. Kubas.
Thank you very much.
If you at home would like to get involved in the conversation, please call the number at the bottom of your screen. Our operators are standing by to take your calls. Thank you for joining us this evening.
Thanks for having me.
Tell us a little about the work you do with the sleep medicine program.
Well, the Austin Medical Center Sleep Medicine Program has been up and running for about 7 years now, and we evaluate, diagnose, and treat various sleep disorders. Certainly one of the more common sleep disorders is sleep apnea, but we see the full spectrum of sleep disorders and the full spectrum of ages from kids to elderly patients. So,
interesting. Yeah. And certainly in that group are insomniacs, sleep apnea, and who else would be involved?
There are other sleep disorders, certainly. Again, sleep apnea would be one of the most common sleep disorders. Insomnia would certainly be another very common sleep disorder. We deal a lot, it's kind of on the TV commercials and things now, restless legs syndrome, which relates to other sleep disorders called periodic limb movement disorder. And there's more rare disorders such as narcolepsy and other conditions of excessive sleepiness. So there's various sleep disorders that are known at this point in time.
Interesting. Our topic for tonight is insomnia, a sleep disorder that affects 1/3 of all humans at some point in their life and up to 15% as a chronic condition. Let's start by defining insomnia.
Insomnia is basically, and I think simply defined as a difficulty with either initiating sleep, meaning getting to sleep, or potentially difficulties getting back to sleep if a person is waking up frequently in the middle of the night, or it could be a combination of both, difficulties with initiation or maintenance of sleep. And to be considered insomnia, it certainly would have to be creating problems in one's life and having to be persistent for at least maybe 2 to 4 months' time. We've certainly all experienced brief episodes of insomnia, which is not necessarily abnormal, but a more persistent maybe over a few months type of condition would be more problematic and considering the diagnosis then of insomnia at that point.
And do you see a higher prevalence in certain populations? For example, are women more likely to be insomniacs than men or something?
I think that due to some sleep changes as we do get older, I think many persons in the 50s, 60s, 70s start to present with some insomnia complaints. Sure. That's quite common. There's not a lot of literature to suggest major differences between men and women with the prevalence of insomnia. I think there's some literature to suggest that women seek help maybe a bit more for sleep disorders or for insomnia, but I don't think there's a lot of evidence to suggest major differences between the prevalence in men and women.
We've certainly seen an increase in the number of sleep centers and sleep research labs over the last, say, 20 to 30 years. Do you find that, are they making strides? Or do you find that research has been very helpful?
It really has. It is interesting that sleep medicine is really a young field as far as a medical specialty. Even in the early 70s, there was very few sleep labs nationally. Even just a handful of accredited sleep labs. Now, certainly that's changed drastically. There's hundreds of sleep labs nationally. So I think it's just it's a matter of that sleep disorders really were not understood or really not known.
Sure.
And then when we've started to discover them and research them, the importance of sleep disorders and healthy, appropriate sleep has become much more known for all of us, which is a good thing.
Yes, yes, definitely a good thing. It appears that sleep disorders have been prevalent for several decades. In fact, back in 1930, Dr. Joseph Collins wrote a book called Insomnia, How to Combat It. And in his book, Dr. Collins describes sleep as the chief nourisher in life's feast,
Yes,
which I like that reference.
Well put. Yeah.
He refers to insomnia, however, as an affliction to be cured by enlightenment, determination, and discipline, but not by drugs, coddling, and self-indulgence. Kind of interesting perspective
Yes.
there. How do you feel about that? Are there, what can you recommend as far as sleep regimens are concerned?
There are really many sleep hygiene practices, which most sleep specialists call it the general healthy practices surrounding sleep, which we call sleep hygiene practices. But I think the quote is somewhat accurate as far as diligence and some practice as far as an individual learning different strategies to help with their sleep and their quality of sleep.
Such as? Can you give us a couple?
Generally avoiding clock watching at night is a good practice versus, if a person wakes up continually looking at the clock, that just gets to be more frustrating and discouraging and increases some angst. And so generally, I would discourage clock watching at night, for example. And also, too, if a person is having a problem getting to sleep or staying asleep, I would generally recommend trying to do something distracting and relaxing instead of just trying to lay there and fight themselves to sleep.
And certainly reading books, or is that the kind of activity you're talking
Exactly
about?
Right.
Okay.
And it's different for different people as far as what would be distracting and relaxing. But yes, that's a perfect example as far as reading or music or things of that nature. For some people, TV watching is actually distracting and relaxing. For others, it's kind of more activating. So you have to kind of be careful with what you do. But yes, that's exactly what I'd be referring to.
And certainly in the media, we've been hearing a lot about don't bring your laptop to bed or don't watch violent TV programs at night. Do you agree with that, or what do you advise your patients concerning that?
To some degree, I do say that it's a little bit tomato as far as a person's preferences in the bedroom environment. Some people like it a little warmer, some people like it cooler, some people like it pitch black, some people like a little light. So honestly, with respect to that, it's finding what is comfortable and relaxing for the individual and then trying to implement that. But yes, generally, avoiding activating activities, whether it's television or even vigorous exercise really close to bedtime is generally a good recommendation.
Yes.
That's correct.
In fact, Dr. Larry Weinrock, he's a professor at Harvard Medical School. He had a few pointers. Mm-hmm. He said, for one thing, and this I guess is a controversial topic, but the repeated use of medications to promote sleep can actually increase the problem of insomnia and enable insomnia to become a chronic problem. I don't know, that might be a kind of...
Medications certainly have a role, and again, medicine is somewhat of an art in as far as trying to help patients specifically. It's an individual practice, and different situations require different treatments. But medications are certainly warranted in a percentage of patients. I'd say a smaller percentage of insomnia patients. I think most can really benefit, again, from some of these sleep hygiene strategies and making the environment and other practices that are very relaxing and conducive for sleep. Yeah.
Are there any for sure don'ts? Anything you would say for sure don't do this if you're having trouble sleeping?
I would certainly avoid caffeine, closer to bed. And I've had patients that truly are drinking coffee or caffeinated beverages really right up to bedtime, and that would be a definite don't. Actually, alcohol would be a no-no closer to bedtime. It can make one relaxed, and it actually can help one fall asleep, but the quality of sleep with alcohol use closer to bedtime is actually worse later on in the night. And exercise, too. Exercise is excellent, kind of late morning, early afternoon, but exercise right near bedtime would be a no-no generally for most people. And again, like we talked, avoiding the bedroom clock, trying to do something distracting and relaxing if it's hard to fall asleep. Some of those general strategies can be very, very helpful for people. Yeah. I'd also suggest just being in bed, about the amount of time that would be conducive for a person, meaning try not to be in bed way too long for one's sleep need. You know, usually we need about 7 to 8 hours of sleep. So if somebody's in bed for 10 or 11 hours, the extra hours are probably going to be spent frustrated or awake.
Yes.
So it's kind of trying to identify what is one's sleep need and then being in bed right about that amount of time.
Okay, and
Yep.
just get up
Yep.
if it's been 8
Yep.
hours. Say,
Yep. Try to
do
keep a
something
regular
else.
schedule, and if you can schedule your sleep at a time that's conducive for you. Some people are night owls, some people are morning people, and trying to schedule it to be helpful in that regards is also good to do. Yeah.
And you talked a little bit earlier about how sleep apnea is probably the most chronic, or the most
One of the most common Yes.
conditions that you see.
Yep.
And you have a machine here. Would you like to show us how that works and
Sure,
tell us a little
sure.
bit about how, you know?
Sure. Sleep apnea is the condition where the airway, the back of the throat area of an individual during sleep relaxes, if you will, too much. And then the airway can narrow or actually close off during sleep. And so we would usually do an overnight sleep study to try to identify and to diagnose sleep apnea. But one of the more common, effective, and safe treatments for sleep apnea is this. And this is called CPAP. CPAP is an acronym.
Let me just ask you about the sleep study. I'm
Sure.
sorry to interrupt you.
No
but
problem.
So before the prevalence of sleep research labs, how would we know exactly how severe the sleep apnea is
Really,
in an individual?
Yeah, before that, and really without an official sleep study, typically you're not going to know. It could be mild, moderately severe, or severe. And so the sleep studies really do help to clarify the severity of sleep apnea.
Okay, so even if you had mild or moderate sleep apnea, would you use this machine?
Good question. In milder cases of sleep apnea, there are more options. CPAP is a treatment option in mild sleep apnea, but there's maybe sometimes just avoiding one's back when you sleep. Sleeping more on your sides is an option.
Sure.
Weight loss is typically a very helpful option.
Sure.
A 10% weight loss will usually reduce sleep apnea by 20 to 25%.
Interesting.
And there's other options too, oral appliances, there's surgical options. But when it comes to more severe sleep apnea, CPAP is one of the safest and most effective options available.
Neat. And how does it work? Okay, now.
It's just a fan, honestly, and it blows in air, excuse me, at a constant pressure. And so it blows in through the tubing into the mask and down towards the lungs. And so it serves the purpose of being an air stent or an air splint in the back of the throat.
Opens up that pathway.
Exactly, and prevents the narrowing and closure of the airway. And so part of the sleep study is to try to identify the optimal pressure for the individual to help to stabilize the airway. So it's just room air. It's not oxygen. It's just room air like we are breathing right now, but it's just pressurized at a gentle pressure.
And how do you find that optimal setting for each patient?
Again, that would be typically during the sleep study. There's a sleep technologist that's working with the patient for the entire night. So they're watching
Interesting. I didn't know that.
real-time parameters of oxygen levels, breathing parameters, and so it's titrated accordingly to stabilize the airway, stabilize the oxygen in real time during the person's sleep.
Interesting.
Yep, yep.
All night long
All
during
night
the
long.
sleep.
Yep.
That's neat.
Yep.
So generally, does a person, do you kind of work out all the kinks in one night?
Generally, we do, yes.
Okay.
Sometimes we're not successful in what we would call a split night study. Our goal is to diagnose it and then to treat it.
Okay.
We're usually able to accomplish that, but sometimes people need to come back for a second study or things like that. Yeah, but usually we're able to do both.
Sure.
Yeah.
And we talked a little before about the role of exercise for insomniacs. Does exercise impact sleep apnea patients as well?
You know, I think
is that different?
It's a little different. The largest impact I would see with sleep apnea, and it's not for everyone, but generally people with sleep apnea are generally heavier, a bit overweight.
Sure.
Not all the time, but oftentimes. So exercise, dietary modification would be very, very helpful for weight loss and therefore reducing sleep apnea severity in general.
Sure.
Yeah.
I did see a study about exercise as it relates to insomnia that I thought was fairly interesting. In this particular study that was conducted actually back in 1998, it's called the Association of Physical Activity and Human Sleep Disorders, so addressing sleep disorders in general, but primarily insomnia. They found that in both men and women, regular activity or exercise was associated with a reduced risk of disorders of both initiating and maintaining sleep, and that if these individuals engaged in regular exercise even one time a week, that it reduced their sleep disorders, or the daytime tiredness, or the likelihood of the sleep disorders by about 37%, which I thought was a high number. Yeah. And that individuals of all ages, I love this part, who exercised slept better, and that increasing age did not appear to mitigate the beneficial effects of exercise on sleep. Let's talk a little bit about age, and I know that you had brought this up to me before, and I thought that was an interesting thing to tie into this discussion. Let's talk about it both with regard to insomnia, maybe first insomnia, and then sleep apnea. What age patient, let's start with sleep apnea. What age patient do you generally see coming into you with a sleep apnea issue?
It's middle-aged patients, even 20 to 50 to 60 range. I've certainly had adolescents that have bad sleep apnea.
And is that related to weight?
It oftentimes, again, is.
It
oftentimes is. Sometimes in younger individuals, it's related a bit more to tonsillar tissue, to upper airway anatomy, but it still can be related to weight even in younger persons. But yes, age and sleep apnea, one aspect of that would be women that are postmenopausal are at higher risk for sleep apnea. So there is some premenopausal protective effects of hormones that are, if you will, lost after menopause. So
can you give us an example, just out of curiosity, of what change occurs physically in them that causes sleep apnea?
I think what that is again the loss of these protective estrogens, progesterones that women would have prior to menopause. Those hormones have an effect on the upper airway.
They do. I didn't know. Interesting.
Stabilization and maintenance of upper airway tone.
Sure.
And so,
makes sense.
If you lose that, then you would be more susceptible to sleep apnea. So women postmenopausally assume some of the prevalence of men as far as prevalence of sleep apnea, but premenopausally they have quite a bit of lower prevalence of sleep apnea.
So higher in men prior to...
Yes, that's correct.
That's interesting. That's interesting. And then now back to insomnia. I know we talked about it affects all ages, but who's your typical patient?
I don't know, I guess, if there is a classic patient, but there again, maybe, people would present that are a little bit older, maybe in the 50s or 60s or 70s. And again, I think there's some physiology behind that, that as we age, our sleep architecture or our sleep quality does change a bit, that light stages of sleep become a bit more prevalent, deep stages of sleep become a little less prevalent as we age, and so there's more awakenings during the night. And so I think because of that, I think as we get older into the 40s, 50s, 60s, and beyond, awakenings and some insomnia becomes a bit more likely, or at least the complaints of insomnia.
Sure.
And so there is a definite effect on sleep architecture, sleep physiology as we age.
And this is not only due to bladder control, which is a primary complaint, but certainly, I'm sorry, go ahead.
No,
it's not only due to bladder control. This would happen regardless of if you really needed to wait to use the bathroom. Is that correct?
That's correct.
Okay,
that is correct.
Interesting.
I have had, I think that again would be published in the literature. Many patients with more significant sleep apnea have more frequent nocturia, in other words, having to get up to void at night. And it's interesting that people that have been treated for sleep apnea, usually again in the moderately severe to severe range, do notice less frequent nocturia. And again, I think there's some physiologic mechanisms behind that. But you're right, as far as aging, it would not just be due to the fact of having to use the restroom at night. It would be
But because you're waking to use the restroom at night more frequently, then is that impacting your ability to get back to sleep? Do you think in some cases that might be a...
It can be the case, and whether it's to use the restroom or the neighbor's dog barking or a child waking up.
Anything waking you up, sure.
It's just, again, more strategies that a person should implement to try to help them reinitiate sleep. And And so awakenings, a lot of people kind of want to go to bed at one point and wake up at another point and remember absolutely nothing in between, but that's typically not a normal expectation of normal sleep architecture. We do have some awakenings at night as we cycle through the different stages of sleep. So awakenings at night are not pathologic or abnormal. It's just kind of what one does with them is important.
But you indicated that as we get older, you have longer periods of light sleep. So that means you're getting less REM sleep?
That's correct.
And how does that impact them during the day?
You know,
or does it?
You know, I guess I'm not sure if I have the answer to that one. No, but you're right. REM sleep would be a deep stage of sleep, and then another deep stage of sleep is called slow wave sleep.
Sure.
And that is when we're, you know, in the deepest stages of sleep, we're less likely to awaken and things from those stages of sleep. So I think it's, again, maybe just part of aging that we lose a little bit of a percentage of those deep stages of sleep and replace them with the light stages of sleep. Regrettably, that's not great news in that sense, but that is clearly been shown with various studies.
Sure.
Yeah.
We're going to take a break now and look at a health trivia slide. We do have a caller, and the question that caller has is, what is the best over-the-counter medicine, or what would you recommend as an over-the-counter medicine? If
I would recommend, you know, most of the over-the-counter medications, you know, Tylenol PMs or Advil PMs, these PM types of medications, most of those have an antihistamine as far as the PM part.
Okay.
And so the classic antihistamine would be Benadryl or diphenhydramine is an antihistamine. And antihistamines have a side effect of making us a bit drowsy or sleepy. If anybody has taken an antihistamine, one may notice that.
Okay.
Yeah. And so there again, I wouldn't necessarily have one being better than another, but usually it would be the antihistamine to try to help with sleep initiation or maintenance, provided again that the person is really implementing and learning more about sleep hygiene practices. But if that's the case, and if a person needs a brief trial of an over-the-counter preparation, I don't have a big problem with that, really.
Okay,
yeah.
So that might be a good thing to start with.
Yeah, yeah.
And we talked a little before, you said the persistence, if it lasts 2 to 4 months, maybe you should seek some help.
Yes.
And at that point, maybe we could classify it as a problem or something that would need further attention. Is that correct?
That's correct.
Okay. What other warning signs can people look for, like maybe I need help?
You know, I think it's the duration, like you've mentioned, and maybe just how it's impacting one's life. If a person is feeling more sleepy, less refreshed, if they're more irritable, or they're just having other mood problems or things like that, or noticing poor concentration, things of that nature would be signs of maybe seeking out some help. But again, if a person is having some periods of time of insomnia, but it's really not impacting their life really in any way, it might be worthwhile just practicing various strategies and maybe an over-the-counter preparation to try to help with that. But so I think it's duration and then how it's affecting one's life in various aspects, work or social aspects of life.
Okay, so say I feel like I have these warning signs of insomnia, and I come to see you, and you mentioned this before, but let's put it all together and synthesize the plan. I come to you, and you tell me some of these sleep hygiene tactics to try to use at home. Maybe I go home and I use them, and maybe they're somewhat effective, maybe they're very effective, but maybe they're not effective or not effective enough. I come back to you. Our next play, I guess you would say, to look into some sort of pharmaceutical, providing that I've tried over-the-counter medicines. And what would you tell me to use it only if it's persisted so long, or how would that work?
Yeah, I think the scenario that you described, if you've had this for a period of time, we've talked, you've tried various good sleep hygiene strategies with maybe, say, modest effect or maybe sometimes minimal effect, then, and maybe then you've tried an over-the-counter preparation. Yes, I think in those situations may be reasonable to try a prescription sleeping tablet.
Sure. And if I've tried that and that's had modest effects, then we might go to something a little more serious as far as medication is concerned.
Right.
And can medication, do the medications just get you over the hump, so to speak, or is there a long-term indication, or are there different medications for both? Is that?
Some of the prescription sleeping tablets have gotten an FDA indication for longer-term use, even 4 to 6 months type of use. So
okay, so long-term would be 4 to 6 months, which still isn't too long.
You're right.
Okay, interesting.
Yeah, and other medications that are not necessarily made for insomnia, specifically some antidepressants kind of have a sedating effect, so some of those are used to try to help people with insomnia problems. But again, I think it's a small percentage of people that would need long-term, soporifics or. But some people do. A small percentage of people do need that. But again, I think the mixture or the combination of maybe medications and sleep hygiene practices and education really get a person kind of over that hump to try to help. Yeah.
Dr. Kubas, we have one more caller with a question about night terrors.
Okay.
I know this is something we haven't addressed, but it's a good question. Are night terrors genetic, and how can you overcome them?
Yes, it's a good question. That's typically a pediatric type of sleep disorder, and night terrors typically happen in children when they're in slow wave sleep. Okay. So it's oftentimes in the first third of the night is kind of the classic history of sleep terrors. A child may wake up and look totally disconcerted, have a blank stare, maybe screaming inconsolably. And a lot of the times the parents will say, I've tried to console them, and it actually seems to make things worse. And so,
what about adults, though? What about night terrors in adults? Less common, but what?
Yes, it is less common, but
what can they do?
Typically, again, it's going to be keeping the environment safe and making sure a person isn't going to hit something or things like that, or injure their hand or things like that. But usually in kids, they're going to, if you will, outgrow them. Okay. Sleep terrors in adults, if it's persistent, if it's very disruptive, if it's injurious, then maybe that individual should have a more formal sleep evaluation.
Okay, and is there any treatment for that sort of thing?
Sleep terrors can represent other things too. Again, it would be unlikely, but sometimes people are having nocturnal activities due to nocturnal seizures, seizure disorder. There are some medications that can help with sleep terrors, but oftentimes, again, it's going to be trying to keep the environment very safe for them. Yeah.
And perhaps counseling, do you think it could be an effect of something bothering them?
It could be, and sometimes, nightmares or things of this nature can overlap with trauma or things of that nature. So you'd have to dissect that out and understand that better. And if it would be related more to that, then certainly therapeutic interventions would be appropriate.
Interesting.
Yeah.
Thank you. Everything you've said tonight has been helpful and interesting, and I really appreciate your being here.
Yes.
Join us next week, and we'll be talking about the H1N1 virus. Join us Wednesdays at 6:30 for Health Connections. Thanks for watching. Inserting everything that